Well, I have the privilege today to chair a very interesting topic, and I would like to make it as an open debate after some short presentations from my presidium. Well, sure. As I told you yesterday in my introductory remarks, there are huge differences between member states in terms of access to treatment. That's what I stand for at European institutional level, and that's what we need, that's the area where we need to do more. And we will have some examples which will be presented to you today from different countries. But we will also talk about what the European Parliament is doing about cross-border directive. And we will also try to define the term advocacy, where some people hang on and they try to, or they define it differently, and they come to no end, I would say. That's why we need to get more and more involved, and we need to find out what has been done and how properly until now, and what we still have to do from now on. Well, health is managed by member states, you might know already. It's not yet an EU competency, and this is what we have to change in the future. And this is what we need to stand for all together. You might have heard about Directive 52, which I mentioned yesterday, which allows patients to buy their medicine from different countries, no matter where they get the prescription. This will indirectly force the national governments to adapt their legislation in terms of medicine, in terms of internal market rules regarding commerce of medicine, and in terms of improving their medical infrastructure, because otherwise people will be willing to get treated in a different country where they get better conditions to the same price. And this is exactly one of our ideas from the European Parliament's level, from the European Commission side as well. But this is only a small thing we have done until now. We have also cross-border directive in terms of access to healthcare. We will get to know more about this shortly. But it's very important to me that the patients who bestly know what they need bring their contribution and come up with their idea. That's why we will keep it short today, and we'll leave more space for your new ideas. Your ideas will be taken over by me and by Europa Colon as well, and this will be the base of discussion, of further discussions at European institutional level. Now, I would switch to a concrete example, and my colleague, Dr. Adriana Melnik, will present you how to define access to treatment, what's good, what's bad right now, what should be changed, and she will also bring up some examples from our own country, which is Romania.
Hello. Hello, ladies and gentlemen, and thank you very much for this opportunity. How do I get on my...
It's another presentation, I suppose.
Yes, mine.
Is the microphone good for you?
No, this is good, but I don't know how to do it.
It's not with you.
There's a technical glitch.
No?
Yes.
Thank you. So when I first heard about talking about access to best treatment, it came to my mind the word of a song of John Lennon, which is Imagine. How about if we imagine a perfect society, ensuring a perfect health system, providing perfect services? It would be good in an ideal world. First, we have to have a goal. We have to know what we want to do. We heard so much these days about personal medicine and about having very good services in some countries. We have to have an image where we want to go because, as we say, if we do not know where we are going, we might not get there. Patient rights vary in different countries. From the Romanian Patient Rights Law, which was issued in 2003, the Romanian law says patients are entitled to the highest quality services available in the society. So we go to reality. We are talking about real resources. We have human, financial, or material resources. It's just that in our day, we are moving from a Romanian society to an European society. Patients are considered to have rights and to access services around Europe. When we talk about cancer care programs, we are talking about a continuum of prevention. We need to promote a healthy lifestyle, otherwise we are going to keep on having more and more patients every year, and we have difficulties to treatment, even the ones that are existing today. And then we need early detection, we need screening programs, and high quality treatment care and palliative care. And when we see what is more important, is prevention or quality treatment, they are all important. It's like a body. It's like a body. We cannot say a limb is more important than another one. I cannot say my left hand is more important than my right hand. We need prevention, we need early detection, and we need treatment because patients are sick now and they need their treatments now. And of course the palliative care for their more advanced cases. In all this we have two parts. We have an awareness that has to grow at the population level, and we need to talk about provision of services. So when we talk about access to cancer care, we have a lot of issues we need to talk about. First of all, it's availability. To have access to services, we need to have the services, and we have to have the providers. If the services exist, we have to look at the accessibility. They have to be accessible from a transportation point of view. If a service is available in another district, or we had even in my district, I'm coming from a big university town, but there are people sick in rural communities which have no public transportation to come to the services. And then if they are accessible, they need to be affordable from a financial point of view. We need issues related to insurance or reimbursement, and they also need to be acceptable. The language, the cultural sensitivity, and even options for treatment needs to be acceptable for patients. And last but not least, we talk about the quality of services. So when we look at all these issues, we realize that in access to cancer care, financial, it's a very important issue, but it's not the only one. Access is very much about organization and about a good organization that could provide good services. So in every country we need a good cancer plan, a realistic cancer plan, we need policies, we need programs, and we need resources. We have regarding the patient rights, we are talking about the relationship, and I like so much what was said before in Germany, the relationship between the patient and the medical system. The model changed from the paternalistic model where the medical field or the state knew everything and it was empowered to make all the decision making, and we are moving toward a participatory model. So what should cancer patients do? Cancer Patient Association, we provide services. This is true, but the most important role for our association is the watchdogs. We have to look at what is not functioning well and to stand up and talk about it. We have to advocate and we have to lobby, which means we have to try to attempt to influence the legislation in our countries. Very similar to Romania. Romania, it's a 20 million population in 7 districts, 41 in 7 regions and 41 districts. We have 3 oncological institutes and some sections in the hospitals in the districts. In Europe, in green, it's the trend of incidence in Europe. In red, in Romania, the incidence is going up both in Europe and in Romania. In Romania, we still have a lower chance to get cancer. We do not know why. Problem is when we look at the standardized death rate, which in Europe, in green, it's going down. In Romania, it's still going up. So we have a lower chance to get cancer, but if we get cancer, we have a higher chance to die because of it. Colorectal cancer is on the 3rd place for in the women case, and on the 2nd place for men. We have no cancer plan, or we had no cancer plan until last year. No reliable national cancer registry. We have indeed very well trained medical providers. We have such good medical providers that each year almost 2,000 medical providers are leaving the country. Good part is that we have a national oncological program and an insurance system that is covering theoretically all patients. But for the past years, the list of drugs covered by the insurance was not updated. Last year, we are using the same treatments developed 6 years ago. And until last year, when the cervical cancer screening started, we had no screening at national level. So what we do as Cancer Patient Association, we are very much involved in awareness campaigns and in support services, in advocacy and lobbying, because we did such a good advocacy and lobbying time. Since last year, we were involved in the development of the cervical screening program, and now we are involved in the development of the National Cancer Plan, and we hope we are going to get to a reliable, realistic, and efficient national cancer plan and into the reform system. And the Minister of Health declared this year that he will go work closely with the Association of Patients in Romania. Thank you very much.
Well, if we talk about differences, we are not talking about only healthcare system. We are talking also about differences in educational system, which is directly linked to healthcare. We are talking about differences in terms of technology, which is not existing in every country in the same way. You saw we have 20 million people in Romania and only 3 oncological centers. Is it enough? For sure not. So that means there is a lot to do. So, but let's see how the situation is in Portugal, and I'll invite our colleague from Europa colon Oporto, Portugal, and you present this.
Thank you very much. Good morning. I ask a minute for Katia outside of the time, only to say welcome to the new groups that came this year to join with us. The Europa team is a good team. Europa team is a good mission that is to save lives, and all the people needs to be with us. And also in the body of Yola, to make my regrets and to say the congratulations for the organization of this conference, and also for the size and for the excellent organization that we have done this year. I remember some years ago, because I usually to come some years before, and it's very different, and thank you very much for all your job, and I ask you a compliment for everybody. You don't stop the time, I saw. Okay, I'm talking a little about what's happened in Portugal about colorectal cancer and oncology disease. As you know, it's normal in Europe, but the increase of life expectancy and the increment of chronic disease, and also the difficulties on the society, the economic way, will bring new challenges for all the national health systems. The oncology disease in Europe, this is the numbers that you know. In Portugal, you have 7,000 new cases by year. Of course, you have no cancer plan, you have no screening, and you have no oncologic data. The next year's expectation, as we hear yesterday Geoffrey to tell, it's 10 up to 2030 we have more 30% of the disease, and 2060 we have near the double of the number of cases. I don't spend a lot of time with this illustration, but it's the increasing of the disease in Europe and all the world. Portugal, it is in the middle also. The incident rate also. And the diabetes, Portugal is the first one in the beginning. We are near the top. It's bad for us. Also, the research and development in Portugal are decreasing because the clinical trials you are talking in the coffee break are decreasing in Portugal because you are missing financial, we are missing recruitment, and we have a long waiting time for national clinical trials approval. It's bad because last year, even for the money sense, Portugal gets 72 million euros for clinical trials that enter in Portugal. This is the decrease of the new recruited patients since 2009 until 2012. Also, the time for approval time that is more than 100 days. Between 2006 and 2011, less 33% of studies go into Portugal. Portugal is lower in the number of patients for clinical trials because the recruitment is not very good. The physician not have time to talk with the patients, and I thought that is one of our jobs also in Patients Association, that is to inform, to publish, to talk with the patients and to tell to him what is the advantage, the inconvenience, the risks to be included in the clinical trial, because the consentiment normally it's not new for the patients. And the practical consequences are the increase of waiting time on complementary diagnosis, treatment startup and chemotherapy, the lack of access on new therapies, as already you are talking about that, the lack of access of new innovative therapy. I think last year there is no one new. And the solutions for the site of patient associations will be to fight every day, is to fight to restrictive and economist policies in the health area, the implementation of a national treatment guidelines of colorectal cancer. In Portugal there is a project, but don't pass the project. There are not accessibility and equity to the treatment of the state of art to the people and equal in the total country. We must promote preventive attitudes, early screening, program of promotion of health in the young people. I must talk to you because I hear today this morning to talk about the young people and so on. Europa Con Portugal School Prevention Program has done near 4,000 children 11 to 13 years old, finished in June 2003. We are 1 year inside each school. Our people that are going there are only professionals of health, and we found more than 38% children with over 8. I took you some pictures about what we are done in this program. This is not a good picture because this is also a training for parents of the people, because we involve teachers, 11s, pupils, directors of the school, and also the parents, because for the inconvenience of to don't have at home what they have at school. Some pictures of the young ladies. All the databases are protected for the government. This program is approval for Minister of Health, the coordinator of the program of the school. We have 12 professionals in the schools all over the year. General assemblies for the students, inquiries inside the classrooms. And we think also that we must improve health professional and patients' communication. It's a lack of the style and of the time and the way that the physicians talk with the patients. We must create a citizen national provider. We thought this in each country there will be, in Portugal there are 4 or 5 organizations or departments of the government, but each one don't work because he thinks that the other one that must do the job. We understand that you need one person by country. The knowledge of the rights and duties must be told to the patient on the first attendance, and of course changing curative for prevent health policies in a sustained way. As you know, the Element Trust Barometer, that is a world study about the confidence of the people in the organizations, tell to us a lot of time that the NGOs is the best organization about the people have confidence between companies, media and the government. And it's a capital that ourselves has in the hands to develop in the best way. In our opinion, the NGO's role must be direct intervention in the community, at least for the screening, increase new patient support solutions. Europacol and Portugal released last month Reiki, yoga, hypnotherapy, acupuncture for Europacol and patients free of charge. All the things that Europacol done to the population is free of charge. We increase the patient capacity in getting credible information, knowledge and counseling. What we must say that it's our first priority to Europacol in Portugal, it's the empowerment of the patients. The patients must be not, we are here that 2-3 years ago, the patient in center, but in the practical, there is not. We must really to try to put the participation of the patients in their main decisions about therapeutic way. And how to do lobbying, because lobbying is very important. We are in the city in the north of Portugal, Oporto, that is the best trial for tourism by the national guides. It's only for you to know. You are invited to visit the city. And we must know 15 days to Lisbon, because Lisbon is the political capital, and it's only for that you make lobbying, because we have, I think that Europacol remember that in 2010 we have the first international Portuguese workshop only for screening. Was there the Minister of Health in the time, not the other no. 2 days ago there are no government in Portugal, but in the old times. And the political says to us that it's not for a question of money, because save lives saves money also in Portugal. And after that, we understand and we put in the new Europacol and Portugal Council for politicals, for 4 parties that was placed in the national parliament. It's that way, as of course Peter agree with me, that we can have the improvement of screening in Portugal. The other way it will be very difficult. Of course, we must improve also our influence for the media. The media don't like to talk about colorectal cancer, bowel cancer, don't want to talk about that. Also, we must influence by the European Parliament. The last time that you are in Brussels, we try to get them free parliaments of Portugal. It was a victory, but tell us also that when we follow up, when you talk to the people, when you show our work, your colleagues came. It's not by the politics, don't care about that. Peter, it's a good example of that, and we Portugal have 3 of them there. Only in the sense of the increasing of patient empowerment. We belong, I'm always finished, we belong in Portugal, the Gulbenkian Portugal platform for a sustainable health system that is managed for Lord Nigel Crisp for UK, that working in the work for develop and modify all the program of health in Portugal. Europacol is one of the 20 perits, the 20 people that was there. And all the work that is done this month before must pass for these 3 triple aims. only we can reduce wastes in health if we improve care, if we improve better health. We call that triple aim and triple game, and more qualitative life, reduce wastes. It's not the contrary. And as Marta told yesterday to us, the economic criteria can overtake human needs. Thank you very much.
Thank you, Victor. Victor Neves, CEO, Europa Colon, Portugal. Well, we see we have different examples, but people are doing something, and that's why I appreciate so much Europa Colon getting more and more involved in these issues and in representing the needs of the patients. Well, we need to keep it short. The crucial and the central question is, can the European institutions still do something, even this is not an EU competence yet? And what do they do, or what have they done until now? What should they do more from now? We will get it to know from Kaisa Imonen Karalambus. I hope I pronounce it correctly. She will tell us about cross-border health directive, which has been adopted recently. Please bring up some details for the audience, and then the question will be taken at the end if possible.
Thank you, Chair, and thank you very much, Europa Colon, for inviting me here. It's really a pleasure to talk to such a nice audience. I'm not going to go into great detail about what EPF is. You have a description in your program, but I would just like to, first of all, highlight that we now have 61 member organizations across the EU, and that Europa Colon is a recent member, so welcome, and we look forward to working with you. And I would also like to highlight that EPF is a cross-disease patient umbrella organization. So our work does not deal with disease-specific issues. That's sort of your work in your own area. What we focus on is issues that all our members from different diseases and different countries all agree that are important for all patients with chronic conditions. And I would like to show the new mission statement that we adopted at our last AGM, which was in May this year, which actually introduces an important shift in emphasis. It really puts the patient in the driving seat. I think that's a strong message, that the patient community should drive the kind of policies that we want to see. So, about the cross-border directive, I'm going to focus in the short time that we have here on three main areas to hopefully inspire some thought and some questions. The first being quality and safety, the second being equity of access, and the third being information. I'm not going to tell you what's in the directive. I'm not going to go into the detail of what is prior authorization, how the reimbursement works, and so on. I do have a kind of solution for those who wish to have that information, though, and I'll come to that later. So, the cross-border healthcare was, as was mentioned, it was adopted in early 2011, and the transposition period will come to an end on the 25th of October this year. That means that all the member states by then should have put that, those provisions that are in the directive into their national legislation and should have put in place the necessary structures to implement it. So that's an important deadline to look forward to. From that date, the provisions will apply to Europe's patients to attain cross-border healthcare and be reimbursed for it. And before I go into the quality and safety issue, I would just like to say that the importance of this directive for us is perhaps direct in the sense that it does codify the right of patients to access healthcare in another country and get reimbursement for it. This is an important legal codification. However, maybe there are other indirect areas in the directive that will be even more important in the longer term. And one of them is the quality and safety. because the directive actually says that member states should first of all put in place standards for the quality and safety of their healthcare provision, and that they should cooperate with each other in developing those standards and guidelines, and that they should be transparent and provide information on those standards to patients and the public. That is an important legal basis for European collaboration towards better quality and safety. And the impact of that, of course, will only be seen in future. Also regarding the continuity of care, when patients go abroad, the directive says that they should have continuity of care when they return home. The question is, in practice, how we are going to implement this. It doesn't specify how this should be done. A lot of patients have expressed the need for better information on what kind of quality and safety standards apply to specific health professionals and specific healthcare providers when they look for cross-border healthcare. And it's important that this information should be made available for patients, because the aim of the directive, it's not exactly to encourage people to go abroad, but it is to enable patients to have an informed choice about what options are available to them. There is a slight concern we have in that these quality and safety provisions that I just mentioned do not explicitly apply to e-health services. So it will be seen to what extent cross-border healthcare is going to be provided through e-health and telemedicine services, and how that's going to work. We also have a slight concern, and here I have to go a little bit into the detail of prior authorization and reimbursement, in that when patients ask for prior authorization of a cross-border treatment, it can be refused on the grounds of safety and quality. Now, the aim of this is good. It's to discourage patients or prevent people from getting substandard care. But it's not clear how the safety and quality risks will be determined. And all of these areas are areas that are still being worked on, and it's really important for patient groups to be aware and advocate in their own countries. I would also like to say that this is a particularly important issue generally for European cooperation. Some years ago, we couldn't really talk about quality and quality standards at the EU level. Now it is a topic, and including in the new joint action on patient safety and quality of care. So our members have for a long time been saying that actually we should have European quality standards for healthcare. And you couldn't say that in the Commission working groups or to member states. And I wonder if this perhaps is a small step possibly towards that direction. The second area I want to touch on is the equity of access, because this is where I think the directive sort of is a little bit lacking, and we worked very hard at EPF during the legislative process to insert specific provisions to safeguard equity, and unfortunately we were kind of partially successful in that. There is a principle in the directive that healthcare provision should be based on non-discrimination, universality and access to good quality care, equity and solidarity, and those are, of course, the common values from the Council conclusions in 2006 that should apply to all European health systems. So there should not be any discrimination in terms of who could access cross-border healthcare. However, the directive says that patients will have to pay up front and they will be reimbursed afterwards. So clearly that is a very concrete barrier for many to access healthcare abroad. We wanted to set up a system of direct payments so that when you do have to access healthcare abroad, your member state and the member state of treatment, the authorities would use a system of direct transfer so that the patient wouldn't have to pay anything in advance. There's already a system in place for this. It's used for the transactions under the coordination of social security systems, and member states are already using it, but they did not want to mandate it for the cross-border healthcare. However, member states can do it if they want to. So I think we should ask them to do that as far as possible. The second issue is reimbursement. Of course, reimbursement is a major question of equity of access. The directive says that patients can be reimbursed for the cost of the treatment to the same level that they would be reimbursed in their own country. Of course, they are free to reimburse more if they want to. So, for example, if your member state decides to reimburse your travel costs or some extra costs you may have because you have a disability, they are perfectly free to do so, but they don't have to. The third issue is prior authorization. There are certain conditions for prior authorization relating to the complexity of the treatment and whether it is subject to certain planning requirements. So in a nutshell, simplified, if there is one night spent in hospital or if the treatment uses very complicated medical infrastructure or equipment, then the member state can impose prior authorization. And we feel that while there's clearly a rationale to this, member states want to control the way they use their health resources, but it should not become an obstacle to equitable access. And finally, I want to mention the concept of undue delay, because one of the refusals for reimbursement is if the same care could be provided at home within a reasonable time limit. Who's going to set this time limit, and will it be the same in Sofia, in Frankfurt and in Dublin? Clearly there are different understandings in different member states what constitutes an acceptable wait for a patient to receive care. So this is something that we need to keep an eye on, and I wonder if it would be possible to arrive at the European agreement on what constitutes a reasonable time for a patient to wait. Then I want to say a few words, coming to sort of the conclusion. I just want to say a few words about information, because this is another really crucial aspect of the directive. Of course, information should meet the patient's needs. It should be provided at the right time when they need it. It should be comprehensive and so on. The aim of all this is that the patient should be able to make an informed choice. And at the moment, we feel, based on feedback from our members, that there is actually a lot of, there's a great lack of information, even about the basics of cross-border healthcare and what the directive actually is and what it contains and what it does not contain. Also, depending on your country, depending on the structure of your health system, you may have different expectations, you may want different information. So the important thing is that the directive sets up national contact points in each country, whose job will be to provide patients with exactly the information they need and all the information they need to make an informed choice. So we think that this is very important, and the way these contact points function should be assessed continuously, and then we need to tell the European Commission what is working and what is not working in different member states. The first report, by the way, will be produced in 2015, so 2 years from the entry into force, the Commission will, for the first time, report on how well it's working. And that's another deadline for patient organizations to keep in mind, because the Commission really wants to hear from us. So I'm not going to go through this slide, you will have it later, but it just illustrates that what the national contact points will provide and what patients want to know. There are very specific questions that patients want to know about, and some of the things that the contact points have been set up to provide are not, do not meet the patient's needs. So, for example, just to point out that a lot of patients who have given feedback to us want information about patient organizations to be included in the national contact points. And when treatment options are discussed, that quality of life should be taken into account and so on. But, sorry. Okay, just to finish, I want to say a few words about patient involvement, because this directive is very vague in the sense that very few of the things that really matter to patients are mandatory. A lot of the provisions are optional. So how it really works will only become evident after member states have started implementing it. We have a lot of expertise and experience between us that we can actually help our member states to develop those services so that they meet the needs of patients better. And we want to help, we want to share our expertise. We think at EPF that patients' involvement in this process is not optional, it's absolutely a necessity, otherwise the directive will not be implemented so that it actually meets the patient's needs. We also think we can help disseminate information and make sure that it comes down to the grassroots. We think that this involves a sort of sea change in the way national authorities relate to patient organizations. They should recognize that they need to engage with patient groups, that they need to have an ongoing dialogue and partnership. It shouldn't just be one consultation, and then we're done. And to finish, I would like to point you to a couple of resources that we have developed at EPF. It's called the Toolkit for Cross-Border Healthcare, and what it is actually 2 documents, one of which is a guidance document, and it says, basically it gives all the provisions of the directive and what they mean for patients, and also suggests areas where patient groups can advocate at the national level. And the second is a set of recommendations, and that's actually targeted towards the national decision-making bodies to tell them how we would like them to interpret the specific provisions of the directive. So those are quite good tools, I think, and we are updating them and adding more information as it becomes available. So they are available on our website. And meanwhile, I would just really like to invite you all, please, to get familiar with the directive, read the materials, for example, the ones that we have prepared, and start monitoring and talk to your national decision makers. Ask them what they're going to do about equity of access, for example. And then also let us know what's happening in your countries. And next year we will organize a number of information events, hopefully, in different EU countries. This is something we're currently developing to really inform the patient communities on the ground about the directive and about how they can get involved in this process. So you will have some links to the further information that you can have a look at later. And with that, I think I'm just about finished. Thank you.
Sorry.
We have to vote now?
Very well.
Yeah. Well, then I have to put. Do we have someone who counts the votes, or you have a? It's done automatically. Yeah. So before we continue with Geoffrey, which is one of the most important speeches for today, let's put to the vote the questions. Do you think the directive can help improve the quality and safety of healthcare in the EU? Like I say, this is a directive, and for those who don't know yet, European directives become mandatory for every member state within a certain set-up period of time, and then this has to be translated in the national legislation, and then it becomes relevant for every EU citizen. So please vote on the question if you think that the directive could influence directly or improve the quality and safety of healthcare in the EU. You have the voting machine in your hands. I see. All right. Well, there are still 15% which do not believe in what the European institutions are doing. What? They don't know. Well, it's for me the same. Well, do you think the directive will improve access to treatment for cancer patients in this case? 5 seconds to go. Oh, that's a critical figure. So almost 40% do not really trust that European institutions or the directive in this case could help patients suffering on cancer.
Can I comment on that?
Oh, please.
Could I just comment on that? I wonder if it's not so much distrust in the European institutions, but maybe distrust in the member states implementing the provisions.
Yes,
because
yes, sure.
we have heard, for example, recently coming examples from Spain, that some Spanish hospitals are not accepting even the EHIC that patients are presenting. So, some member states could use the financial crisis as an excuse to not implement the cross-border healthcare. So I think we have a lot of work to do at that level.
It's a good point, but don't forget the EU legislation is done also by representatives of every single member state. We have from Spain and from all the member states actually people in the European Parliament and also in the European Council. So it's made by us, by the representatives of the European member states. It's not done by the governments, but you always have to take into consideration what your party, what your country's position is when representing or not an article or an amendment in a directive. So that's why it cannot, and if you then adopt this directive, this becomes mandatory for every single member state. Of course, there are in many cases, many countries which say, well, there is economic crisis, we don't have budgets. But then you should vote against at the European level. We have this discussion in the European Parliament very often, and especially in the trialogues with the European Commission and the Council of the European Union, because we are in the co-legislation, and the negotiation processes are quite tough. I can tell you, especially now on budget, on cohesion policy, common agricultural policy, internal market, data protection, and so on. We have quite tough negotiation at this level. But once the directive is adopted, so initiated by the European Commission, went through European Parliament, through political groups, through committees, and then through plenary meeting and plenary adoption, then it goes to the Council of the European Union, so the representatives of the national governments, representatives of the national ministries, and if this gets adopted by us, by the members of all the EU member states, then it becomes mandatory for every member state. That's why this is not a reason. Of course, some governments face problems in terms of implementing some directives, but this is mandatory. They have to do so, because otherwise we cannot speak about it. You want to very briefly, please?
Yes, it's just small comment on that European member countries made some legislation and so on, and I agree completely. It's the matter of the countries which made and didn't make that legislation they adopted. Will they respect that and do as much as they can? Because it wouldn't be that for the first time that they're not even doing what they're writing. We will move to the politics if we continue, but in every single issue we can talk about it. Are all members of the European Union following the international law or European law and so on? They're just doing in their favor when they're jeopardized or something like that. So I completely agree that it's up to a single country, even if it's the one that made the legislation.
I'm not sure you have read the European Union's functioning treaty, which every member state has signed, the acquis communautaire. You might have heard about this. And there is no way not to fulfill or not to implement directives of the European Union. There's really no way. Of course, there are some countries they see that differently. There are some directives which allow a little tolerance in terms of implementing, but there is really no way not to implement a directive which has been adopted at the European level. Well, let's move on.
Can I just ask, is there a survey you've done as to who is...
Please take the mic.
Has there a survey been done as to who is implementing the directive and who
A
isn't?
service?
Not set up
A
yet.
survey.
It's not set up yet. It's not set
yeah.
up yet. Not until October.
25.
No. Well, I will come to that because this is already a different question, different topic. Well, let's move to the next one. In your country, are patient organizations active in advocating for patients' rights in cross-border healthcare? Yes, no, maybe. Wow, that's a nice video. You need to take a picture of it. Well, you see, we were talking these 2 days about differences between countries. And this figure clearly expresses that we don't have the same understanding in every single member state. And that's what we have to work on, to continue to push up, to identify the responsibles. In my eyes, the European Commission would be first, national governments, European Parliament, and then supported by your organizations. And not only yours.
If I could comment on that, yes, you are absolutely right. And in fact, the European Commission has made it very clear. The European Commission people who are working on the cross-border directive have made it very clear to us at EPF that they really look forward to having the patient organizations' views and that they really welcome all and any feedback during this process. And yeah.
Kajsa, I have to say, I nearly had a nervous breakdown when the document arrived. There were pages and pages and pages, and no patient organization has the time to go through this.
Which document?
When you sent it round for us to read, to comment on, to put our input into, I mean, maybe what we need to do is do it as the umbrella organization on behalf of our groups and take an assumption. But it really was daunting, the number of pages that one had to read. And even if we'd wanted to be involved, and I think we were, Jeffrey, by the time we got, no, well, we weren't. I know that by the time I got round to it, it was probably too late. Is there some way of simplifying all this? Because my fear is that if these documents are confusing for us, can you imagine what they would be like for our members whose English might not be perfect?
Yeah, I take your point. Are you referring to the EPF document? Yeah. No, I take your point. We're constantly trying to strike the right balance between making it simple and not losing the sort of the essential detail, because a lot of the devil is in the detail of the legal text. So yes, and when we review our toolkit, we'll aim to make it more simple and present it also perhaps visually in a more easily readable format.
Kajsa, I think we still have to develop in some countries, at least in Germany, what I can speak for. What is patient advocating? Nobody knows in Germany. That must be defined, and we don't even have a word for that. We have a description, but we don't have a smashing word for it, which sinks in and immediately explains, is self-explanatory.
Yeah.
Maybe you should come up with a good word.
Yeah.
Invent it.
No, that's a good question. Thank you. Jeffrey will tell us some words about this. And like Kajsa said, the new directive foresees that in every member state there will be a service financed by the European Commission or by national governments in order to provide information about all the possibilities for patients to be treated in their own country, but also abroad. Also information regarding reimbursements and complaints will be provided. So that means this is a new element of which will be implemented very soon, and every patient can just address to this institution and get any information, whatever they want, whatever disease they need the information for. This is well, but let's move on, if you allow me. There is a question. There is a question of Mrs.
I wonder if there are any guidelines being developed for cross-border access to clinical trials.
That's a whole other directive and a whole other conversation, I'm afraid.
Yeah. Yes, but this is a topic at the European institutional level. Yeah, it's not done yet. You're right. That's why it could be an objective for us. Do we have other questions so far? Thank you for voting. I now introduce Geoffrey, the policy director of Europa Colon from United Kingdom. Geoffrey, I would love to get from you what's advocacy, and do you think lobby is important for the representatives in order to improve the communication to policymakers and to decision makers? And then please be open to take other questions.
Thank you. Right, so many of you might think I'm going to be talking about the tsunami that is affecting your health systems, but no, I'm not. I'm talking about making waves, and what I am going to try and define in my own way, and I hope it meets some of your criteria as well, is what I think empowerment is about, and empowerment includes advocacy. The good news is that many years ago, there is no way we could have talked about empowerment and patient advocacy in the way that we can do now. It's written into EU documents, it's an accepted principle in the EU, and in most countries, the power of the patient and the voice of the patient is clearly heard and respected. My concern is that we are not working enough with our clinical colleagues, that many of our clinical colleagues are abstaining from the responsibility that we might wish to embrace, or them to embrace, in making our voice even stronger, because they have, and in many countries are much more respected than patients. When you tried to be a patient advocate, to work with your clinicians would actually provide you with a much stronger case. But there are many initiatives going on at the moment that are opening up opportunities, and UPATI is one of them. Empowerment and advocacy are key platforms also for Europa Colon, and these are organizations who have been to the past 2 meetings that we've organized will know that we are putting this on the agenda on a regular basis. It is the only way forward. But why is it important? It's a very sensible question, and I'm sure it is in many of your minds. But the journey of any patient, I believe, is both a public one and a private one. And that's really what I want to try and highlight. It's private because any diagnosis, and especially a cancer diagnosis, affects you to the very soul of your being. And for many people, they cannot move out of that moment of diagnosis, that moment of fear and crisis that affects a diagnosis of a life-threatening condition. They don't want to know about choices. They're quite happy to accept what their doctor says, go home and sit quietly in front of the fire until the moment comes to say goodbye to their families. But that is not what the future holds, I believe. What we need to do is move beyond that, and move beyond the impact of a diagnosis and embrace the importance of choice. Being in charge of your diagnosis and your health, taking advice and taking support, but making an effort for yourself. For example, how many patients today know their KRAS status? How many patients ask for their pathology results? All of this is important information in building up your own profile and moving out of the stage that I'm suggesting is a state of fear and denial, because that knowledge will give you confidence. This gives you the opportunity to ride the wave. This gives you the opportunity to stand up with your head high and talk in public and privately with confidence about who you are and what you are experiencing. We've heard from Barbara. It was a major fight for her, but she wasn't prepared to sit in front of the fire. She was putting the wood on the fire. She was making it burn brighter, and she has shown us that by burning bright, she's kept herself alive, her family happy, and she is a fighter. And that is the goal that we should all, as patients and citizens, be emulating. In England, there is a phrase that is called "no decision about me without me." And the purpose of that phrase is to put the patient, me, in the center of the discussion. It is all about me. It is about my actions and about my future and my health. We have to act for our own health. And once we've reached that stage, we can move on. And that is when we can look at a wave like this and say, wow, I wish I had my surfboard. That, when you have reached that point of clinical empowerment, you can take your surfboard and no wave is a challenge. But you can only reach that public stage, I believe, when you've actually overcome your private stage. You have to become an empowered patient first before you can have the confidence to become a public advocate. And a public advocate needs confidence. You can't be a public advocate if you are scared. You can be worried, but you can't be scared. You need to have full control and full confidence about your future. And the importance of that position is, as mentioned yesterday by John Bowes, and I'm sure would be endorsed by Mr. Lujan today, politicians, health ministry officials, and anybody else in the public arena does not know what it's like to be a patient. They don't know what it's like to have cancer. They don't know about the pain that Antonio talked to us about. They don't understand the fear. They don't understand the fact that you've had to have chemotherapy, that you've got to go and throw up for 2 hours and then go to work. Only you can tell them that. But only you can tell them once you're prepared to take responsibility. And take responsibility not only for you, but for everybody who will come after you, because you are opening the door for them to follow in your footsteps. And the exciting thing is that every year this role is further endorsed and acknowledged. The Cross-Border Directive specifically asks for patients and citizens to report back so that the EU Commission can take action against those countries that are not implementing the Cross-Border Directive. This is the first chance that we as citizens of Europe have had the opportunity to put our health on the agenda with the full endorsement of the EU, and we need to grasp it. Because if we don't grasp it, they can't make the report, they can't take action against other member states, and things will not change. We have to become empowered patients. Europa Colon, as I have said already, and there's a test in the slide, and I want to see if anybody picks it up, works on the principle of empowerment. The whole point of me coming on board at Europa Colon was trying to move empowerment into the essence of the work that all of us do. And the test was that the launch of the white paper was not in 2011. That's when we started it. The launch was in 2012, and the launch of the barometer was in 2013, both events hosted by Mr. Lujan, thank you very much, who stepped into a breach, and we were very grateful. It is our point to raise awareness of cancer, and we're planning to do that at meetings in Poland and in Spain over the next few months, the first one in Poland in November and the next one possibly in Spain in February. We're in discussion with various officials in the Spanish health system with the point of trying to raise awareness and understanding of how cancer and the issues around cancer, the commissioning of cancer, will be changing over the next years. Because we need to work smarter, not only us as patients and patient organizations, but also the healthcare professionals and the commissions in those countries. The other thing that we're hoping to do much more of is work in countries where access is not equal. in countries where that tsunami does appear to be coming very close to your doorstep. And finally, we need to work more and more efficiently with our partners to raise the bar so that we can, in Germany, create advocacy as a public tool so that there can be unified approaches by patients to the whole issue of health. That's all I have to say, and I hope that I've addressed some of the points you needed. Thank you. So my first question is a point that I touched on earlier. Do you think that a clinician has a role in helping to empower patients?
No.
Yes, that's a role to play in helping to empower patients. That's a relief. Question 2. Should clinicians partner with patient advocates in campaigning for better cancer treatment and care? Thank you very much. I've certainly got a platform for next year to work with. And finally, do citizens and patients have a responsibility for their own health? You've had 2 days to work this out, and I hope you come up with the right answer. Otherwise, you'll be back here next week.
Oh, my God.
Hooray! We worked.
Thank you. Well, we are a little bit out of time, but we still would like to open the round for questions if there are any for the audience, for anyone, or to bring out new ideas you think would be of interest for you to be taken over to the European Parliament, by Europa Colon, or you bring up new ideas which we together could push up to the European Commission or any or some national parliaments and national governments.
Okay, I'm going to get it down.
Take a microphone, please.
Just how realistic is it that health becomes a competency?
Of the EU.
Yeah, because, you know, we have to accept there are some battles we have to put to the side. If we're going to win the war, we have to focus on the battles that are realistic. So what, in your opinion, is realistic?
That's a very good point. I can tell you what improvements and what steps we have taken until now since entering into force of last treaty, which was Lisbon Treaty, entering into force 1st of December 2009. For instance, we are discussing now about cohesion policy, about different directives. And last time when we discussed about the sectorial policies for the programming period 2007-2013, most of the countries did not agree on having money allocated for healthcare systems, for health area. Now we have, only for my own country, more than 1 billion euros allocated for healthcare infrastructure. For clinics, for hospitals, for healthcare programs, screenings and so on. This is a clear sign, this is one of the clear signs that the Europeans accept that we need harmonization in this area and we need common rules in this area. And I see also among my colleagues from also from older member states, which were opposing at that time. Now they are much more open on this issue. And they accept that health is important, like I said, is the highest value for the EU citizens. If you lead a survey among the European Union and ask the people which area or what is for them most important thing to be transmitted to politicians, health will be also in the first place. And this is what we will fight for, and my personal opinion is that we have huge chances to transform health into a EU competence, which is not yet.
So, with the money that Romania received...
Not only Romania, I gave my example, the example of my country.
The monies that are available. Oh, I see, because I was going to ask you, if a country is given money for health, what checks are put in place to make sure that this money is going into health and not into something else?
You mean control systems? Yeah, well, there are a lot. We have an audit system at the European Union level for all the EU funds, no matter if this is used for health infrastructure or for cohesion or for infrastructure or for internal market, competition, agriculture and so on. We set up clear rules for that. From many points of view, these rules are a bit too strong because this leads to lack of absorption. Should be clear, strong, but unbureaucratical. And that's what we have to still work on. And sometimes the member states make it even more complicated. But again, there is clear control. There are clear control rules at the European level set up by the European Commission. So there is no way out. There is complete and clear control. Any other questions? No more questions?
I think you're very lucky today because everybody's tired.
Yeah. Well, what I would like to emphasize in this context, because this was a very constructive and contentful debate. Thank you to the panelists. Thank you for your contribution. For me, it's important that we set up a better communication from now on. Yesterday and today, we talked a lot about this. We are not always able to define responsible people for certain concrete activities, but we should become able to do so. And that's why one first step is, like I said yesterday, when we will have the guidelines, I will put all of them in a guide, which in a handout, if you want, in different languages and distribute in the whole European Union. That's one of my objectives, as far as we will have the guidelines in place, but only for healthcare area. Another thing would be to communicate through the modern communication instruments like social media. And so on. And I was lucky getting to know Ele, which is the PR of this event, and we set it up that we should maybe transmit information not only from our side, from the European Parliament, the European Commission side, but also from your side, through networking, which we can build up together. Like I have now the intention to post on my Facebook every week an information about what's going on, what are the news in this area, and in English, and sometimes not only video messages, 1 or 2 minutes long, but also some links which could be relevant for you. And you are part of some I don't know, organizations, or you have a Facebook page representing a certain organization with a lot of likes. If you distribute this message, if you suggest to this message, this will reach a higher number of relevant applicants. For instance, if I intend to give you clear and short information about certain programs you can access in order to get European funding for certain kinds of activities, no matter if we are talking about screening opportunities, no matter if we are talking about studies on the market, no matter if we are talking about trials, clinical trials and so on, or if we are talking about research and development activities. We should distribute this information so that in 7 years, will not be in the same position like today, that more than half of the money allocated for research, development and innovation will not be accessed by the relevant applicants. This is a concern of mine, should be a concern of all the politicians. But what we can do is only to transmit information. We are not eligible. There would be a conflict of interest if I would build an NGO and will apply for that money. I'm not allowed to do so, but you are. And many others outside you are in contact with are eligible. They should proceed to get that money from the Commission. The European Commission, the European Parliament are interested in giving that money to the applicants because we have set up certain policies. We have set up some concrete objectives, and we know at the same time that we only can achieve that if we support it financially. That's the role of EU financing, and you can contribute to accessing that money much more than we can do. And this is another concrete thing I can propose to you. I will post every week at least one video message or one link on my page with Petro Luhan. You will see a head with a EU flag behind. It's quite easy to identify that it comes from the European Parliament. And then if you like that and then you share these messages or you suggest it further to your associations, to your own Facebook friends, the message will reach a higher number of relevant applicants. This is my aim, this is my objective, to distribute such messages to as many relevant people as possible. And in this way, I consider that I give a contribution to achieve a higher rate of absorption of European funds. You had Gabriela.
Do you have to wait for a call? Okay. You always have to wait for a call for a certain subject, right?
It's a very good question. This is different from program to program. There are some axes, we call it axes, some programs where you only have limited period of times, so-called calls. Yeah, the Commission calls for applications on a certain area. Not only in health care, also transport and energy and so on. And this sometimes lasts 3 or 6 months. And then follows the evaluation by the experts. And then if those who fulfill the requirements will become the financing, will become the budgets. And then follows the implementing phase, which is 1 year, 2 years, 3 years, or 5 years long. And you get then reimbursed by the European Commission. But the good thing is that from the European Commission you get 100% reimbursed. If you go over the national programs, you sometimes have to bring from your own pocket between 5 and 50%, sometimes 70% in some older member states. But from the European Commission, from Brussels directly, you get reimbursed 100%. Even elaborating the projects is an eligible cost which will be reimbursed by the Commission if you get it, if you get through the project, of course. So keep that in mind. That's what I can do. I propose to do together. And if you have any new ideas please let me know, please transmit the ideas to us, and this will be then distributed. And in this way we will build a networking which is useful and of a high importance in terms of making steps ahead. Also ideas regarding cross-border health directives, for instance. Or we will have Directive 52, 2012, which is about access to medication in every member state, no matter where you get a prescription from. There is also every national government has to adapt their IT systems. It's not easy. They have to get accredited doctors. You cannot write prescriptions which will be recognized in Slovakia, for instance, which will be recognized in Barcelona if this doctor is not accredited at the EU level. We have already criteria in place. So this is another improvement we have done at the European level. So, and there is still a lot to do. But working together, I'm quite confident that we will succeed. And especially after entering into force next treaty, where health will become an EU competence, we'll be able to do even more. But until then, believe me, we can do a lot. We have at the European Commission a DG which is called Health and Consumer Protection. They are in charge. Their duty is to come up with new ideas, new concepts, and they even have money, they even have budgets allocated to do so. But they cannot do that, like Jeffrey said. That's true, Jeffrey. I'm with you when you say that many, or the majority of the politicians, they don't know how patients feel like. That's true, I know that. Yeah, I should have been today in front of 800 colleagues from the whole country, because I'm a member of the leading committee in my party, Romania. But I prioritized to come over to meet patients' organization from Europe instead of having a political speech. So this is, I think we can do that, but we cannot do it by ourselves. We have to build up this networking, and we have to become a bit more proactive. And like I suggested yesterday, you have to take the lead. Again, because politicians sometimes have different priorities and lack of time. And if you come up with new ideas, you will always find someone in the European Parliament or European Commission level which will listen to you. If there is no one, I will be the one. So thank you very much for everything, and I hope we'll see us again very soon.